Hello, St. Mary's Medical Center providers. Welcome to your Reverse the Cycle training on MAT initiation in the ED. Our objectives for this training today are for you to understand the evidence-based model of SBIRT or screening, brief intervention, and referral to treatment. And for you to understand what Reverse the Cycle is, all three components of it, and how it's implemented at St. Mary's Medical Center. And then we really specifically want you to understand what your role is in this program as a provider in the initiation of MAT in the emergency room. Reverse the Cycle is a comprehensive hospital substance use response program that was developed in response to the substance use epidemic that we are currently in the midst of. So in 2018, there were 21.2 million Americans who needed substance use treatment. That's 1 in every 13 people. However, only 17% actually received the treatment that they needed. And 31.9 million Americans, 12 years of age and older, admitted to being current, meaning within the past month, illicit drug users. And of course, drug overdose is the #1 cause of injury-related deaths in the United States. Opioid-related hospital use has been steadily rising since 2010. Every year, about 20 million people visit the emergency room for illness or injury, and about 15 to 20% of them would actually screen positive for having a substance use disorder if they were screened. When we look at trauma-related visits, that goes up to between 25 and 50%. Looking at opioid-related inpatient stays, we can see West Virginia has one of the highest rates in the nation, with more than 350 per 100,000 population. And drug overdose deaths in West Virginia are the highest in the states. In 2018, the CDC reported that there were 67,367 drug overdose deaths in the US, and about 70% were attributed to opioids. So in 2018, West Virginia had a rate of 51.5 overdose deaths per 100,000. This graph here shows you the number of opioid overdose deaths between 1999 and 2018. This blue bar represents all opioid overdose deaths, so prescription, heroin, and synthetic opioids combined. This blue line represents prescription opioid overdose deaths. This yellow line represents synthetic opioid overdose deaths, so fentanyl, carfentanil, and this orange line represents heroin overdose deaths. So you can see the opioid epidemic really starts to pick up in the early 2000s, and we hit a peak right here in 2011 with prescription opioid overdose deaths. So a lot of things started to change at that time. You could see that prescription opioid overdose deaths begin to go down. However, synthetic opioid overdose deaths start to spike at that time. So what do we do in response to this? Well, we began implementing Reverse the Cycle. And as I mentioned, this is a comprehensive hospital substance use response program to work to curb the substance use epidemic. We need a more powerful response for patients. So there's 3 components to Reverse the Cycle. There's universal screening, which we also refer to as SBIRT, which is the screening, brief intervention, and referral to treatment model. There's also the Overdose Survivors Outreach Program. That's the second component of Reverse the Cycle. And then there is MAT initiation in ED. That is the third component. And we'll go into detail as we go through these slides about each of those components. So that first component, SBIRT, universal screening. SBIRT stands for screening, or the application of a simple test to determine if a patient's at risk for or may have an alcohol or substance use disorder, Brief intervention is the explanation of those screening results and information on safe use, an assessment of readiness to change and advice on change. And the referral to treatment piece of this is for patients who are screening positive and they're ready for treatment, they are referred for an in-depth assessment or treatment. So SBIRT has been shown to be very effective. For every $1 we spend on SBIRT, we save up to $5.60. It has reduced emergency department visits by 20%, reduced hospitalizations by 37%, reduced non-fatal injuries by 33%, and it's reduced car crashes by 50%. It also reduces the severity of drug and alcohol use and has been shown to reduce arrests. So how do we administer reverse the cycle at St. Mary's Medical Center? The protocol at St. Mary's is that all patients who are 18 years of age and older are going to be screened by a nurse during their nursing assessment. And the tools that will be used are validated screening tools located in Cerner. The first piece of the SBIRT screening is the Audit C, or the Alcohol Use Disorders Identification Test Concise. And then the second piece to the SBIRT screening are these 2 drug questions that accompany the Audit C related to illicit substance use and prescription drug misuse. So for patients who screen a 7 or more on the Audit C, or who say yes to the drug question, they are considered a positive screening. If a patient screens positive, a peer recovery coach is going to be triggered on the tracker board for notification in the emergency room. And the on-duty peer recovery coach is going to conduct a brief intervention and develop a plan with the patient around their use. A peer recovery coach will also complete referrals to treatment when it's appropriate. Peer recovery coaches are folks who are actually in long-term recovery from substance use disorders themselves. And they're also trained in motivational interviewing and many other skills so that they can best use their lived experience to help serve patients who are in active addiction. And at St. Mary's, you have 3 full-time peers who sit in the emergency room. And then you have 1 overdose survivor outreach peer. You'll hear us refer to that as your OSOP peer. And these peers are employed by Marshall Health. The ED peers are going to provide brief interventions and referrals to treatment for patients who screen positive for risky alcohol or substance use. And the OSOP peer provides intensive outreach and follow-up in the community for patients who come to the ED as a result of an overdose. So OSOP really is the second component, again, of the reverse the cycle model. This just shows you what peer integration looks like in the ED. So all patients are screened by the nurse. If a patient screens positive, the medical team is going to alert the peer. There will be a notification on the tracker board for the peer. The peer is then going to review the patient's screening scores, their medical history, and their reason for visit, and then speak with the nurse and ask when it's appropriate to give a brief intervention to talk to the patient about their screening results. The peer will then go in and provide that brief intervention and develop a plan with the patient and schedule any necessary appointments, make linkages to treatment or resources, whatever might best support that patient. So the third component, and most important to you as providers, is MAT initiation in the ED and what we call fast track referrals. So MAT in the ED, or medication assisted treatment, the initiation of that in the ED has been shown to save lives. So this has been endorsed by the National Academies of Sciences, Engineering, and Medicine. There's a committee on medication assisted treatment for opioid use disorders, and they released a consensus study report in 2019 called Medications for Opioid Use Disorder Saves Lives. It's a really great report. I highly recommend you check that out. We find that the risk of opioid overdose death declines immediately when patients with opioid use disorder initiate buprenorphine treatment. There's overwhelming research to support this. Treatment with agonist medication is estimated to reduce mortality by up to 50%, Both methadone and buprenorphine treatment retention have been linked to substantially decreased risks of all-cause deaths and overdose-related deaths, and both medications reduce the number of opioid overdose deaths in the community. Expanding access to these medications reduces the number of deaths due to opioid overdoses. Treatment with methadone or buprenorphine is associated with lower rates of opioid use, improved social functioning, decreased injection drug use, reduced HIV transmission, a reduced risk of HIV diagnosis, reduced risk of hepatitis C, and better quality of life. In 2015, Gail D'Onofrio published this study on buprenorphine. So there were 3 groups involved in this study. The first was a group of patients who were initiated on buprenorphine in the ED with a 3-day prescription and a referral to treatment. The second group of patients were provided with a brief intervention around their use, and there was a referral that was facilitated to substance use treatment. The third group was simply provided a referral to substance use treatment. So when we looked at those patients at 30 days, when this study looked at those patients at 30 days, the group that had been initiated on buprenorphine in the ED, they were still in treatment. 78% of them were still in treatment at 30 days. The group that received the brief intervention and a referral to drug treatment, 45% of them were still in treatment at 30 days. And then the simple referral group, 37% of them were still in treatment at 30 days. And as for self-reported illicit opioid use, the days per week, the buprenorphine group reported between 5.4 to 0.9 days per week using opioids. The brief intervention group reported between 5.6 to 2.4 days per week, and the referral group was 5.4 to 2.3 days per week. Urine toxicology was negative for opioids at 30 days for 58% of those who had been initiated on bup in the ED, and 43% for those who had received a brief intervention and a referral to treatment. And for the referral group, interestingly, it was 54%. So under the Narcotic Addiction Treatment Act of 1974, all practitioners who use narcotic drugs for treating opiate addiction have to obtain a separate registration or the Data 2000 waiver. The DEA, however, has made an exception to this rule known as the 3-day rule. Sorry, an exception to the registration requirement known as the 3-day rule. So this allows a practitioner who's not waivered to administer, not prescribe, just administer narcotic drugs to a patient for the purpose of relieving acute withdrawal symptoms while arranging for the patient's referral to treatment. Not more than 1 day's medication can be administered or given to the patient at a time, and treatment cannot be carried out for more than 72 hours, and you cannot renew the 72-hour period. Patients who are initiated on MAT in the ED, they really can begin to feel better once they receive that 8 milligram dose of buprenorphine, which allows them to better participate in their treatment, and they're less likely to leave against medical advice. They also understand their discharge instructions better. When patients feel better prior to discharge from the ED, they're less likely to use an illicit substance before going to treatment. And patients who receive a dose in the ED and who avoid illicit substance use are more likely to engage in treatment within 24 hours. Patients who engage in recovery are much more likely to comply with follow-up healthcare visits and thus less likely to revisit the ED, and that is our goal. This shows you the workflow for MAT initiation in the ED. Starts here with the patient screening positive and receiving a brief intervention from the peer recovery coach in the ED. Through that brief intervention with the coach, the peer will determine if the patient's primary substance of choice is opioids or not, and if they are motivated for treatment and willing to go to treatment the next day. If the patient is opioid using and ready to go to treatment, willing to go the next day, the peer is then going to recommend that the provider evaluate that patient for their initial dose of buprenorphine in the ED. So the provider will then go and see that patient and conduct their clinical assessment. So they'll review the cautionary and exclusionary criteria and ensure that that patient meets the DSM-5 criteria for opioid use disorder diagnosis. And the provider is then going to ask the nurse to complete the clinical opiate withdrawal scale. The nurse will conduct the COWS. And if the patient scores 8 or more on the COWS, the provider will order the medication and the nurse will administer the medication in the ED and observe the patient takes it appropriately. And the peer will connect that patient to a fast track appointment to treatment, so meaning within 24 hours. At St. Mary's, your peer is going to confirm that the patient is motivated for treatment and willing to attend the next day, as I mentioned, and the provider is then going to evaluate the patient to determine if buprenorphine is appropriate. So again, they must meet that DSM-5 criteria for opioid use disorder, and the provider is going to check and see, do they meet any of these cautionary criteria? So the provider is going to proceed with caution if the patient is on any benzodiazepines, if they are pregnant, or if there's clinical evidence of liver disease. And the provider will not provide the buprenorphine if the patient is appropriately taking prescribed long-acting opioids, if there are acute psychiatric illness going on, if there's acute psychiatric illness going on, or if there's a true allergy to buprenorphine or naloxone. So this shows you the DSM-5 criteria for substance use disorder. Use in larger amounts or for longer periods of time than intended, unsuccessful efforts to cut down or quit, excessive time spent using the drug, intense desire or urge for the drug, failure to fulfill major obligations, continued use despite social or interpersonal problems, activities and hobbies reduced because of use, and recurrent use in physically hazardous situations or despite physical or psychological problems or caused or worsened by the use. And tolerance and withdrawal are also criteria for substance use disorder. So severity is designated according to the number of symptoms that are endorsed here. So 0 to 1, no diagnosis. 2 to 3, there's a mild substance use disorder. There's a mild opioid use disorder. And 4 to 5 is moderate substance use disorder, and 6 or more is severe. So if the patient's clinically appropriate, the provider is going to enter the ED MAT induction protocol order. The nurse will complete the clinical opiate withdrawal scale assessment or the COWS. And if the patient scores 8 or more on the COWS, the nurse is going to let the provider know verbally of that patient's COWS score, and the provider will place an order for the 8-2 buprenorphine naloxone tablet or Suboxone to be administered to the patient in the ED. If the patient's pregnant, the provider will order an 8 milligram buprenorphine tablet. And then ED nurses will administer the medication and observe that it is taken in the manner in which the patient has been educated by the nurse. The clinical opiate withdrawal scale is a method for recording scores for various symptoms of opiate withdrawal, and the nurse will total all the scores to determine the severity of opiate withdrawal and the next plan of action for treatment. 5 to 12 is considered mild to moderate withdrawal, and a score of 8 or more makes a patient eligible to receive buprenorphine. So buprenorphine is a partial agonist. So what does that mean? That means that there is a ceiling effect on opioid effects. It means that it has a very high affinity for the opioid receptor and that there's a slow dissociation from the opioid receptor. And it's formulated with naloxone to block the opioid effect if it is injected, and the naloxone degrades slowly if it's taken orally. So You can see an image here. This opioid, this is the fits very perfectly with the opioid receptor. So you can see when a regular opioid is in that receptor, there's no withdrawal pain and there's a very euphoric opioid effect. Now, buprenorphine, on the other hand, it has an imperfect fit. So it has a limited opioid effect. There's a ceiling effect, if you will. So the patient is not getting all of that euphoria. It stops the withdrawal pain, but the euphoric effect is limited. We do have to be careful when administering buprenorphine because of precipitated withdrawal. So buprenorphine can cause precipitated withdrawal if the patient does not score 8 or more on the COWS. It's more likely if their physical dependence is high and if it's been a short time since their last opioid use, or if their initial dose of buprenorphine is too high. So that's why the dose that's provided in the emergency room is fairly low. 8 milligrams is a pretty low dose. So we can prevent precipitated withdrawal if we administer that first dose when objective signs of withdrawal are present. So when a patient has received that buprenorphine in the ED, the peer is going to make sure that they have secured a fast track appointment within our existing network of community treatment providers. These are programs that have agreed to take patients within 24 hours of receiving buprenorphine in the ED. So the peer recovery coach is going to follow site-specific protocols to refer patients to one of these providers. And they're not going to recommend a patient be dosed unless the patient has confirmed that they will go to this treatment appointment. And we also will not refer these patients unless there is an appointment available. So that is your training. This is the contact information for the president of the Mosaic Group. Her name is Marla Oros. She is a nurse. If you have any questions, please do feel free to reach her on her cell 410-852-4263, or her email address is moros@groupmosaic.com. Thank you so much for your time today. Please do not hesitate to reach out with questions, and thank you for all that you do.